Growth hormone deficiency. This is rare, by the way, and apparently doesn't necessarily just occur by itself. It will occur as, part of a syndrome somewhere. So not sure what to say here. Let's see what the questions were in the mini cases. Discuss the sequentially expressed transcriptional factors, DNA binding proteins that resemble homeobox genes that direct the differentiation and proliferation of anterior pituitary cell types. So here we talk about the sonic hedgehog. We talk about the BMP. We talk about the PIT1. So, and then give classification of growth hormone deficiency. So it's classified into three. So we can come up with like congenital, acquired, or idiopathic, but mainly they classify it as just congenital and acquired. Under congenital, you've got 1A, 1B, and 2B and 3, right? 1A, it's autosomal recessive. 1B is also autosomal recessive. 2B is autosomal dominant, and 3 is X-linked. Congenital, what could cause it? So obviously with congenital, the symptoms must manifest on the first day of life up to 6 months. Congenital could be due to birth trauma like asphyxia, midline defect syndromes like septo-optic dysplasia, mutations of genes encoding pituitary transcription factors. Acquired, this could be tumors or hydrocephalus, vascular abnormalities, major head trauma, or tumors of the craniopharyngioma region. Discuss the causes of acquired hypopituitarism. I think this one in class, we kind of talked about it as being a pan-hypopituitarism, which is like all the pituitary hormones are affected. So the causes of acquired, so pituitary tumor, because we just said there's congenital and acquired before. So for the acquired now, the tumors. So number one would be the pituitary tumors, which is about 53.9%, the incidence, and then followed by the craniopharyngiomas, which is 12.3%, and then idiopathic 10.2%, CNS tumors 4.4%. So mostly the pituitary tumors is the hypothalamic tumors as well, and there are surgical or radiological treatment. So that could be a cause, I guess. So hypopituitarism generally starts with growth hormone, and then if left prolonged, other hormones get affected too. And the question is why? Because the somatotrophs are the most abundant type of secretory cell type in the anterior pituitary gland, about 50%. But this doesn't mean that the growth hormones type is more common. The most common prolactinemia is, the most common tumor in the anterior pituitary will be the prolactin one. Okay, prolactinoma. Discuss the forms of acquired multiple pituitary hormone deficiency. This one, the most common genetic cause of MPHD is mutations in the PROP1 gene. So this multiple pituitary hormone deficiency, it's an endocrine disorder that causes short stature. So it can may occur as a result of acquired lesions in the hypothalamo-pituitary areas, such as tumor, surgery, trauma, or radiation. But it can also be genetic. Describe isolated growth hormone deficiency and insensitivity. So obviously isolated growth hormone deficiency is a condition caused by severe shortage or absence of growth hormone without other hormonal problems, which is rare again. So isolated growth hormone deficiency classifications, same as above, which is the congenital or acquired ones. And under congenital, we said we have type 1A, 1B, 2B, and 3. Type 1A is the most severe. Growth hormone insensitivity is when there's adequate growth hormone, but the body isn't seeing or recognizing it. This is a case in Laron's syndrome as well. Describe mid-facial anomalies associated with growth hormone deficiency. So these ones, I think an image will help you capture it. So, you know, your frontal bossing, maxillary hypoplasia, small mandible, saddle nose, depressed nasal bridge, blue sclera. So the blue sclera that you would see here would just be because of the decreased thickness of the sclera connective tissue. So it permits that visualization of the underlying choroid, so you can see through because of the defect in connective tissue structure. Describe the clinical manifestations of hypopituitarism. So if we are talking of pan-hypopituitarism here, you can talk about all the deficiencies of all these hormones that you find in the pituitary gland, right? You can talk about the corticotroph deficiency, the thyrotropin deficiency, the gonadotropin deficiency, etc. How is growth hormone deficiency diagnosed? Of course, again, depending on which track you want to follow through, but IGF-1 or IGF-BP3, then you can do your provocative tests, depending on what rabbit hole you want to go through. Describe use of recombinant growth hormone and list the indications for growth hormone treatment approved by FDA. You know, we just talk of recombinant human growth hormone here. And apparently it's actually been really successful in Turner syndrome, this recombinant human growth hormone, because they also tend to be very short, and with growth hormone they can have like normal height. It's also been used in AIDS-related cachexia, but it's not common these days, or even in idiopathic short stature. Describe complications and adverse effects of growth hormone treatment. Yeah, lots, right? From your intracranial hypertension, prepubertal gynecomastia, arthralgias, insulin resistance, progression of scoliosis due to too much, if you're giving too much, I guess, slipped capital femoral epiphysis, headaches, nausea, vomiting. Also, since growth hormone stimulates cell multiplication, division, so neoplasm, like development of neoplasm, is a concern. Growth hormone antagonizes insulin action via various molecular pathways. That's a tidbit. Bear that in mind, because insulin does a lot of things, so it's good to know how it interacts with other hormones. So chronic growth hormone secretion suppresses the anti-lipolytic action of insulin and increases FFA flux into the systemic circulation, which also will then cause insulin resistance. Growth hormone deficiency isn't my favorite, and I'm tired. Bye.